Hello, welcome again to another edition of Matters of the Heart, brought to you by Haverhill Community Television and Pentucket Medical Cardiology. I'm Dr. Seth Bilazarian, a clinical and interventional cardiologist at Pentucket Medical in Haverhill, and I'm here with my associate, Dr. Sunny Srivastava, for another edition. This week, Dr. Srivastava is going to review a problem with one of the valves of the heart. We have 4 heart valves. 2 of the heart valves are on the left side of the heart, and one of them is called the aortic valve. Dr. Sunny is going to be reviewing today the mitral valve. I tell patients sometimes this is the inlet valve of the main pumping chamber of the heart. And these valves, any of the valves, but the valves that we're talking about today, the mitral valve, can either leak or narrow, and those are the 2 main things that does wrong. There's some other things it can have problems with, but those are the 2 main things that cause issues, and Dr. Sunny Srivastava is going to review that for us today. So take it away.
Great, thank you. And so, just as you said, the 4 valves in the heart, and the 2 on the left, the aortic valve and the mitral valve. And in fact, I believe at some point in the recent past, we had done a show on the aortic valve talking about new therapies for the aortic valve when they have problems. And similarly, I'd like to address the mitral valve. And the mitral valve is a very important valve as well. And the first part of this that I want to talk about is a condition called mitral stenosis. And that's when you alluded to the narrowing of a valve as opposed to leakiness. We'll talk about that later. But mitral stenosis, it refers basically to a narrowing of the opening of the mitral valve. The valve, I think, one way to explain, it's like a doorway. It opens and closes like this, and when it's narrowed, it doesn't open quite as well, and that causes quite a bit of problems. It can impede blood flow into the main pumping chamber of the heart. That's known as the left ventricle. The chamber above that, or before that, is called the left atrium. There's a couple of different causes, but by far the most common cause worldwide is rheumatic heart disease. It's by far the most common cause worldwide. In this country, it's less and less, but worldwide, it's estimated that somewhere close to 16, 17 million people suffer from rheumatic heart disease. And so that's a lot, obviously. And certainly in the immigrant population here, we see it a fair amount. But by and large, we don't see quite as much rheumatic heart disease here.
Just a reminder to our audience, that rheumatic heart disease is a disease caused by a bacteria called strep, and we've largely wiped out strep because we use antibiotics, and sometimes a little too much, but we sort of use them a lot, and the reason why we see it in other countries is they use antibiotics less. Correct,
absolutely, yeah. So, you know, back in the pre-antibiotic days, or in the 1930s or 40s, where it was really just, just recently discovered, strep went untreated, and it could lead to these complications that would develop years down the road with the heart valve. So yeah, the usage of antibiotics has really wiped this out in the United States for the most part. But other causes besides rheumatic heart disease, there can be just degenerative processes of aging where calcium over time can deposit on the valve, or there's a ring, I guess for lack of a better phrase, around, it's like a frame of the doorway. That can become calcified and thickened, and that calcium can impede blood flow. Sometimes people can get infections that stick to their heart valve. That can sometimes impede blood flow and can cause like a functional stenosis, and that's called endocarditis. There are other rare conditions like rheumatoid arthritis. That's not rheumatic heart disease. It's a little different. Or lupus, or something even more rare called carcinoid or sarcoid. These things can also affect the mitral valve, but they're much more rare and not worth getting into the nitty-gritty details of it. So let's talk a little bit more about how these people present, or what type of symptoms they have, or what the natural course is. And as you talked about, we'll focus mostly on the rheumatic heart disease. That's the most common kind. So let's say somebody has an issue of strep in their teen years, untreated. The seed is planted, so to speak, and then 20, 30, 40 years down the road, they may start to develop some problems. And what happens is the mitral valve, it thickens up. These leaflets that open up, they start to develop calcification on it. They thicken up. They don't open quite as well as they did when they were normal in youth. And then what can happen is, because that doorway or valve doesn't open as well, pressure is going to increase. Let me rephrase that. I don't want to get too sciencey either on this, but it's going to take more pressure across that valve for blood to flow into the next pumping chamber, into the left ventricle. We call that a pressure gradient. And over time, that can have a lot of deleterious effects on the heart size and strength and how it squeezes and where pressure ultimately backs up in the system. I guess it's as sciencey as I want to get on that regard.
So using our analogy we talked about earlier, you said a door frame, and then we're talking about like a door is an opening into a room. So we're going from one room to another with blood flow,
Yep.
and the door doesn't open very well. So instead of the door flying open and the blood rushing into the main pumping chamber, the door just opens a little bit, so that it's harder for blood to get in. So you need to push more to get the blood through there. Is that sort of what you're saying?
Absolutely.
Okay.
Yep, absolutely. And some of the symptoms that one can develop as this valve becomes more and more restricted, some of the most common ones are just simple shortness of breath with exertion. Now that can be present with a lot of conditions, so one should not think that just because they're short of breath with exertion that they have mitral stenosis. However, mitral stenosis, most common symptom is shortness of breath with exertion.
So that's, again, from the higher pressure, and then that higher pressure backs up sort of into the lungs, and it makes the lungs sort of congested, and that makes it difficult. And it's worse when people exercise because they can't get the blood through
Not
their
as much
lungs.
as pumping, your body, your muscle, your heart, wants oxygen delivered, and it can't get there quite as well.
Okay.
So shortness of breath with exertion, easy fatigability, you just tire more easily when you try to do things. This increased pressures in certain chambers of the heart can lead to certain types of arrhythmia. Something called atrial fibrillation is a very common arrhythmia that's seen with mitral stenosis, where the upper chamber of the heart, the left atrium, triggers this, and you have an irregular heart rhythm, and it can often race and go fast, and that actually can cause people to feel really poorly when they have mitral stenosis. When you develop a rapid heart rate, or even if just exercise, you can feel really poorly with mitral stenosis as a result. People can develop clots when they're in this atrial fibrillation, and so that's another concern, that there's a stroke risk. People can develop chest pain because the heart is not going to be getting the blood that it needs to pump properly. There can be what's called right-sided heart failure, where the system is really backed up, and now people are getting swelling in their legs, even in their abdomen. Their jugular vein can become really engorged, and there's certain characteristic findings that we would look for on someone's physical exam there. And sometimes people even cough up a little bit of blood as a result of some of the pressure that's built up and the congestion that's there. So those are some of the most common signs, or symptoms, I should say, that somebody would present with or complain with about. And then when we examine them on a physical exam, before you even get to diagnostic testing, when we examine them, there are certain heart sounds that, again, are probably beyond the scope of this discussion, that are characteristic of mitral stenosis. That, to be frank, myself, and I shouldn't speak for you, but I suspect that I am not as good at hearing that as a cardiologist in India or China or somewhere where they're seeing this rheumatic heart disease all the time. I don't have a lot of it. I mean, how about you? What would you say?
Same with me. I have very limited experience. So only in my 21 years in practice, I see 3 or 4 patients total, all, as you said, immigrants from third world nations.
Yeah, so it's not something that's, we have a lot of diagnostic testing readily at our disposal that we use quickly for this type of thing to get to the bottom of it. And so some of those, go ahead.
So talk about that diagnostic test. So you said a patient comes with shortness of breath. There's a suspicion based on both what the patient says, the history, and the physician's listening of the heart valve. That valve can make certain noises because it's not opening full well, or a murmur can be heard. And if that happens, then what's next steps a cardiologist might take?
So back, again, like I said before, people can have shortness of breath with exertion for a lot of things. And so the physical exam is going to play a very important role in determining what we're thinking is going on here. And so, an EKG, or it's called an electrocardiogram, it's not going to be diagnostic of mitral stenosis by any stretch of the imagination. However, you can see certain things in there. There could be signs of enlargement of certain chambers of the heart. There could be the presence of atrial fibrillation, this irregular heartbeat that I talked about. So you could see that on an electrocardiogram, although you could probably hear that on a physical exam as well. It's just part of the evaluation. Chest x-rays are often done. Someone's complaining of shortness of breath, a chest x-ray makes perfect sense. And you could see certain things that might be non-specific, but you could see enlargement of certain parts of the heart. You might be able to see all the calcium deposited on just a simple old chest x-ray. It wouldn't tell you much about the severity or the pressures and things like that, but it's a tool that's useful. I would not say you would hang your hat on a diagnosis based on a chest x-ray by any stretch of the imagination. The test of choice, and it is indicated across the board, is an echocardiogram. That's an ultrasound test of the heart. It's done for a lot of different things. And it can do, not just take a look at the heart, which it does, and it can take a look at all the chambers, all the valves, can identify if there's calcium, if there's thickening, if there's restriction and opening, if there's leakiness. It can measure a lot of these things, but it also has the added benefit of being able to measure pressures in the heart and pressure gradients, and measure sizes of the openings, or the orifices is the phrase we use. And again, it's a lot of math and a lot of sciencey things there that can do this, but it's a terrific tool for this. And we have certain criteria that we use that if the pressure gradient is this, then it's considered severe mitral stenosis. If it's this, it's moderate, it's mild. Or if the size of the opening is X, then it's severe. And you could look it up on a table or a chart very easily. So that's a very useful part of, actually, I would say the most useful part in the diagnosis of and evaluation of how severe mitral stenosis is. There's some things you can do where, for example, you do something called a stress echo, where a patient may not have a lot of problems at rest. You can see some suggestion of the stenosis. Then you get them on a treadmill, really brings out or exacerbates the symptoms, and then you put the ultrasound back on their chest right afterwards, and you can measure these gradients and pressure gradients after exercise. And there's some, you can often, I don't want to say unmask, but really show how severe the mitral stenosis is when someone's exerting themselves. And so that's sometimes another test or modality that's used to help diagnose or figure out how severe the mitral stenosis really is. Another modality that you're very familiar with, cardiac catheterization. I don't think that is used as much in the diagnostic part of mitral stenosis. However, if someone ultimately is going to undergo a surgery to correct the mitral stenosis, a cardiac catheterization is a very important part of the evaluation, in that you want to see if somebody has concurrent coronary artery disease, that if they were to go in and have their valve fixed, they would fix the heart, the coronary arteries as well.
So you basically told us that these patients primarily present with shortness of breath, especially shortness of breath with exertion, that there are certain exam signs that the cardiologist will be tipped off that this is probably a problem, but that the echo or the heart ultrasound is really the way to make the diagnosis.
Yeah.
So once you come to that and you've concluded that it is really a severely narrowed inlet valve or mitral valve, what do you do? What are the treatment options?
Yeah, so most folks think, okay, well, let's just try medicines first because it's less invasive and we'll just do medicines. However, medical therapy for this, and what I mean by medical therapy, medications, not great. There's some stuff that it can do to get you out of the woods if you decompensate or get sick, such as diuretics, alleviating the pulmonary congestion that you have. So that's useful, but it's not a long-term fix. This is a mechanical problem. If someone has atrial fibrillation, this irregular heartbeat, and is racing, and you have a severe mitral stenosis, you can get very sick and feel very poorly. So giving medications to slow down the heart rate, or even delivering an electrical shock to convert the heart. However, more often than not, people revert back to atrial fibrillation if you have severe mitral stenosis. Giving people blood thinners if you have this atrial fibrillation to prevent a stroke. These are all important measures in the medical therapy, but they're not going to cure the problem or get rid of the problem entirely. And so really it comes down to surgery.
Fixing the door.
Yes, fixing it. It's a mechanical problem. It needs to be fixed. And there's some other procedures that can be done too. Surgery, more often than not, when it comes to mitral stenosis, involves a mitral valve replacement. It's an open heart surgery, taking out the valve and putting in a prosthetic valve.
So that, like you just described earlier, the whole door frame is cut out, and a brand new door casing with the brand new doors is placed back in.
Yeah, and that's sewn in, and it's a big major surgery. And if you were diagnosed with coronary artery disease along the way, you'd have your coronary arteries bypassed at the same time as well, and one-stop shopping, try to get it all done at once. That's the typical procedure of choice. There's something called a mitral valve repair, which is a better procedure for when the valve is leaky, not so much when it's stenotic like this or narrowed like this with all this calcium. You just got to get it out of there. There is a procedure that certainly you're probably more familiar with and probably performed it as well. That's something called a valve.
Mitral valvuloplasty.
Yes, I was going to say valvotomy, but valvuloplasty.
Right.
Where a balloon, catheter-based from the groin goes up, balloon is placed in there and just cracks it open, basically. Have you been doing?
Well, again, as we said, very infrequently because we don't see a lot of this disease.
Yeah.
Actually, the last patient I did was one of your patients, a patient from the third world. And that patient did very well, but it is an option. But there are certain criteria, and this back to you, more in your expertise, about certain criteria that make it a good operation, that operation versus the open heart operation. Certain characteristics of how bad the valve is scarred and whatnot, and if it's not as scarred, it might be a good one for that. You want to handle that?
Yeah, I mean, off the top of my head, I don't remember every little scoring system on this thing, but yes, and the amount of calcium that's present in the door frame, the annulus or the ring around there, plays a big role. And if there's a certain amount of leakiness of the heart valve, that plays a role as well. So yeah, lots of information to be had or to be learned first before you make a decision on which procedure to go with. But more often than not, I see people ended up getting valve surgeries for this type of thing and getting valve replacements. And then there's the type of valve that's used. There's tissue valves, there's mechanical valves. It's a individual decision made on a case-by-case basis of what that person's needs might be. My anecdotal experience, when I was training, was always under the impression that the mechanical valves last much longer than the tissue valves, that if you're young, get a mechanical valve, it'll last longer. But I gotta say, the patients I've been seeing, the tissue valves are lasting a long time. I don't know, is that your anecdotal experience?
Yes, it is.
They don't just burn out after 7-8 years like I think we were once taught a long time ago. So that choice, though, is definitely made on a patient-by-patient basis. So I think that's the gist of it for mitral stenosis. I mean, one key thing about preventing this is antibiotic therapy. If you have strep infection when you're young, is a very important part of this. And it can be, the antibiotic treatment can be delayed by even a week, but it's still worth doing it to help avoid these complications.
Okay, so that was a great, I think, summary and review of the topic of mitral stenosis. We sometimes abbreviate it as MS, a narrowing of the main inlet valve of the heart, in which you told us it's shortness of breath, a heart murmur, an ultrasound, and then ultimately some kind of mechanical fix, most commonly surgery, but sometimes a balloon treatment for the narrowed valve that improves the opening of that doorway. So that's the narrowed valve. Are we going to handle next the mitral regurgitation, which is MR, which is a leakiness of the heart valve? What's the story with that?
Yeah, and so now when the main squeezing chamber of the heart, the left ventricle squeezes, in an ideal setting, you want the back door, the back valve, to be closed and all the blood to flow forward out to the body. But for a variety of reasons, that valve may be somewhat incompetent, and we'll get through the different reasons, and blood may leak backwards in the system, so to speak, and goes up to the left atrium and can back up even further. And now, the next time the blood, the cardiac cycle comes through, the next time blood flows into the left ventricle, there's more blood there than really should be, because you have the usual amount plus the regurgitant amount that came back during the prior squeeze. And over time, that can cause problems and lead to problems. Many people have a tiny bit of mitral regurgitation. It's really inconsequential clinically. We call that trace mitral regurgitation or very mild mitral regurgitation. The heart's not a perfect machine. There's going to be a little bit of that happening. It's not a clinically relevant thing. So this is not, what we're talking about here is not referring to those folks, because I'm sure many of our patients have trace or very mild mitral regurgitation, and it's not a concern. So mitral regurgitation, it can be caused by various mechanisms related really, again, to the structure of the valve or the whole apparatus that helps tether it and hold it down, or the door frame, again, the annulus or the ring around there, that can be stretched out in certain conditions. That can play a role as well. It can come from, as you age, there's just degeneration of the valve, doesn't do as well. There's cords that hold it down, that can rupture and break, and that can lead to the valve leaking. Rheumatic heart disease we talked about for mitral stenosis, but can also cause mitral regurgitation. This infection that I talked about before, endocarditis, when it can lead to destruction of the valve and severe leakiness of the valve. If someone has coronary artery disease and blood flow, they develop ischemia, diminished blood flow, that can sometimes lead to mitral regurgitation or leakiness of the the valve. Or if someone has an enlarged, weakened heart muscle and the whole thing stretches out, that can lead to, we call it functional mitral regurgitation, that can lead to mitral regurgitation as well. It is not an insignificant problem. It occurs in about, and that's significant regurgitation, occurs in about 2% of the population. Men and female and women equal, doesn't affect one more than the other. And what ends up happening with these people, again, I'm focusing on the people with significant mitral regurgitation, is that it can ultimately lead to what we call volume overload of the left ventricle, the main pumping chamber of the heart. And that's because it's with each heart cycle, cardiac cycle, it's getting the usual blood flow, and then it's getting the extra that leaked backwards. And so over time, that left ventricle can stretch and stretch and stretch. And if it does it for too long, or if it's too severe or too much volume going through, it can start to weaken, and that's a problem. We don't want that. And so we watch people very closely when they have significant mitral regurgitation with the testing that we'll talk about, although we've already talked about some of it, to look for some of these parameters, whether the heart is enlarging or weakening, or whether there's other certain parameters we see, all play a role in deciding when it might be time to fix the mitral valve. And again, the symptoms again are somewhat similar, that people, as the mitral stenosis or congestive heart failure, where people develop shortness of breath with exertion, easy fatigability. Sometimes they can't lay flat very well because they can't breathe, so they sit up. They sometimes wake up in the middle of the night gasping for air and have to swing the legs over to the edge of the bed. Those are all signs of congestive heart failure. People can develop racing heart from atrial fibrillation just like you could in mitral stenosis for the same reasons, where there's extra pressure put up in the left atrium, it stretches, and that can be a trigger for atrial fibrillation. Now, a lot of these symptoms occur with chronic mitral regurgitation. It's built up over time. And so the symptom can be gradual in onset, and people treat it with medicines. But when it happens suddenly, let's say there's a rupture of these cords that tether and hold the valve down in place, that severe acute increase in flow going backward overwhelms the heart because the heart has not had time to compensate over the years where it's grown bigger and has been able to handle and stretch and handle this more. And so when that happens, people are in a medical emergency more often than not, where they fill up with fluid fast, they can't breathe, 911 has to be called, and they often end up in an intensive care unit with a breathing tube in and extremis, and get treated and then can fix the problem after the fact there. But that's a difference where acute versus chronic. So again, going down the same path we went with the mitral stenosis, how do we diagnose this in people? Well, you take the story or the history from a patient, and you're suspicious of something when you just talk with them, but then the physical exam is a very easy one from a cardiologist standpoint to detect mitral regurgitation on a physical exam by the certain characteristic murmur that you hear. For me, it's a much more common problem and a much more identifiable problem than the mitral stenosis would be, certainly. We hear it all the time, every day we see this problem. So the physical exam certainly is, tips you off. And again, just like in mitral stenosis, when we talked about a chest x-ray, there's some certain things you could see, but it's not diagnostic by any means. Same thing with electrocardiogram, the EKG. You can see the same types of things. You can see enlargements of the left atrium on an EKG. You can see atrial fibrillation, but it is not by any means diagnostic. And so it all rests, again, on the echocardiogram, the ultrasound test of the heart. There's lots of things you can do where not only can you appreciate the size and strength of this main squeezing chamber of the heart and the left atrium, the size of that, you can see the structure of the valve, where the leakiness is coming from, how leaky is it by certain, again, I don't want to get too scientific, but you can see how leaky it can be. You can calculate pressures, you can calculate the area of how much is leaking, and gives you an idea of how severe the leakiness is. You can measure pressures in the lungs and things like that. And so the echocardiogram is really the mainstay of diagnosis and following people. You could have people who have moderate to severe mitral regurgitation who feel pretty good and whose left ventricle isn't enlarged or isn't weak. So you can watch these people closely, but you may need to do an echocardiogram every 6 months on them or once a year, or follow them very, very closely. And sometimes a more invasive type of echocardiogram called a transesophageal echocardiogram, where you go down the throat and get unobstructed views with an ultrasound right in the throat of the heart, is sometimes required to help figure out whether you could repair the valve if you're going to ultimately fix it versus replace it with the valve versus repair, or if you just can't get a good picture because someone might not have, might be obese and you can't get a good ultrasound picture, sometimes the transesophageal echocardiogram is necessary. So, we are, I think, going to run out of time soon, but to talk about the treatment of this and going into medications, when someone is acutely sick, like I talked about, where the cords rupture and there's an acute problem, it's a medical emergency. People are treated with diuretics, people are treated with certain intravenous medications that might decrease the work the heart has to do, but ultimately you're going to have to get that patient to surgery. People who have moderate mitral regurgitation and have some mild symptoms, often managing them with diuretics to help get them through, or if they have atrial fibrillation, to treat the atrial fibrillation. Blood thinners and heart rate control medications are all useful measures. And patients who have what we call functional mitral regurgitation, and that's the type where you have a weak heart muscle, it's big, it's enlarged, and the annulus, that door frame, is all stretched out. That's a bigger problem, or a more difficult problem to treat and handle, and it's actually a poor prognosis for folks. There's not you treat them like you would for their cardiomyopathy or their weakened heart muscle, but surgery in and of itself for those folks isn't really quite as useful or as good, but it can be done sometimes to alleviate symptoms. But really, it's the other types of mitral regurgitation that we're talking about, and getting down to the actual treatment, surgery. It's preferable, and we won't get into the specifics of why and how, but mitral valve repair is, generally speaking, preferable to mitral valve replacement for a variety of reasons. And there's certain things that would allow one to repair it versus replace it when you look on these ultrasounds and look where the problem is and what the actual problem is. But mitral valve replacement is, again, a common surgery. And I guess we might as well just touch on real briefly some newer therapies that really just coming to market. Similar to what we've talked about before with the aortic valve, there's an approach from the groin, a catheter-based approach that can also help the mitral valve, something called a Mitral Clip. That's been recently approved by the FDA, although it's been approved for a while in Europe, I believe for a few years. That can be used as well.
So that was a really tour de force review of two important mitral problems: the mitral valve, or the main inlet valve of the heart. The mitral stenosis is the narrowed heart valve that we first dealt with. And Dr. Sunny just completed a really extensive review of a much more common problem that we see quite frequently in our practices, and that's mitral regurgitation, or a leaky heart valve.
And I think we're going to have to, I was going to talk about mitral valve prolapse. We'll have to do that on another segment at some point because we're running out of time.
Sure. So we'll leave it there today to just summarize. The mitral regurgitation is, again, commonly shortness of breath, again, a heart murmur, a different heart murmur, but one that's characteristic of this leaky heart valve. And Dr. Sunny made a special point that if you happen to have this leakage occur suddenly, then that's often an emergency. But if it develops over years, the heart can accommodate and can just be followed and ultimately recommended for surgery when appropriate, when the heart starts to get in trouble. For my patients, I sometimes tell them, I don't know how you explain this to patients, but I tell them that when the heart pumps, if it pumps a cup of blood each beat, if the mitral valve is working, a cup of blood goes forward. But if this valve is not working, when the heart pumps, a cup goes forward and a cup goes backward. So every beat, the heart has to pump 2 cups. So it sort of explains how this, I think, is a much more of a strain on the heart than we would expect. So I think that this is those are two really valuable reviews that you've provided for our audience to help understand better mitral valve disease, how it comes about, and the treatment options ultimately end in surgery for most patients. But watchful waiting for the timing of surgery is what really is important to be done with the cardiologist and the patient, following closely with regular exams and echocardiography. So I'll thank my colleague, Dr. Sunny Srivastava, for a really great review of this topic, and invite you back next time for another edition of Matters of the Heart, brought to you by Haverhill Community Television. Thank you and good evening.